Good evening, everyone. Thank you for joining us. I know you probably had a very long day already, so it's, we're really very privileged to have you with us this evening. My name's Darren Morton. I'm the Director of the Lifestyle Medicine and Health Research Centre here at Avondale University. And it gives me great pleasure to introduce our speaker tonight, who'll be talking on the topic of nicotine addiction and smoking cessation counselling for GPs. There really is I think a great need for information that will be presented tonight, and I know that you'll really appreciate the presenter, who is Professor Renee Bittoun. We are very privileged and honoured here at Avondale University to have Professor Bittoun, who is leading the nicotine addiction unit here within the Lifestyle Medicine and Health Research Centre at Avondale University. But she also has many other strings to her bow, if you like. So she's also a visiting professor at Notre Dame University and the University of Prague, I do believe. I know she also is fluent in about half a dozen languages, so quite an incredible lady. She's the editor-in-chief of the Journal of Smoking Cessation, which is published through Cambridge University Press, and she's a member of the NHMRC Working Committee on e-cigarettes. But also as a clinician, she just has a wealth and great depth of experience in this space of nicotine addiction and smoking cessation. In fact, my understanding is that she actually was responsible for opening the first smoking cessation clinic in Australia in 1979, I think it may have been. So she's been at this game for a long time, and she really has made a tremendous contribution to tobacco control, smoking cessation within Australia and abroad as well. So it gives me great pleasure to introduce and welcome Professor Renee Bittoun to us, and she'll be taking it from there. We will have time for a Q&A at the end, hopefully. And so we'd invite you to, if you've got any questions as the webinar proceeds, is just to input your questions into the Q&A function, or the chat function will be fine as well. And hopefully we'll have some time to respond to some of those at the end. I'll also point out that this session will be recorded, and we'll be sending out the link to you, because there will be a lot of really powerful information that I know that you'll want to revisit later, and so you will have the opportunity to do that. And Professor Bittoun is also happy to share her PDF of her slides with you as well. So without further ado, please welcome Professor Renee Bittoun. Thank you for joining us.
Thank you so very much. Thank you, everybody, and good evening. And for those who don't know, what is going on behind me is a crop of illegal tobacco. For those who don't know this, we in Australia haven't been growing tobacco for a long time. It's illegal. So that's an illegal crop behind us. I'm just going to share my screen with you so that you can see, I'm hoping, behind me. And you can tell me if that's all good to go. This is who I am, and what Darren was saying was correct, but I just wanted to make you aware that I don't have any conflicts of interest at all. I don't work for the tobacco companies, evidently not, and I don't also work for any of the pharmaceutical companies that make pharmaceutical smoking cessation products. I'm not on any of their boards, and I don't take any hospitality from any of them. And I think it's really for everybody, this is an important issue to discuss and have people declare prior to giving a presentation on smoking cessation, and obviously on the very next presentations people have been giving about vaping. Really, what I'm going to be talking about is to talk to you about the regulations, and particularly at the moment, the new GP subsidies or reimbursements that GPs are entitled to with item numbers. And why I'm doing that now is because this, some of you might have noticed, these are relatively new medical services that you can claim for, because they're dated from the 21st of July, which is not that long ago, with what I think is a lack of clear or absence of directions for yourselves. So this presentation tonight is really for yourselves about counselling smokers. I will come to e-cigarettes or vaping towards the end of the night tonight, but we will leave that and how these things will be negotiated for another evening. So tonight's talk is really how to put some ideas for you, some thoughts for you, how to help your smokers negotiate or manage. That's the word I like to use, and you'll hear me saying that a lot more often, how to manage their smoking. So in case you haven't seen this, this is on the health insurance website. There are 18 items. They range from 9360 to 93705, just giving you the bare minimum about this. Reimbursement for short consults, long consults, telephone, face-to-face phone services. These are details that you probably know more about than I do. I am not a physician. I do not prescribe. I specialise in smoking cessation counselling. And what is on this particular health insurance now agenda is the content of 5 components to be addressed by doctors regarding counselling advice and the management of smoking, without really any detail at all. No explanatory notes, no fact sheets, no nothing. Can I say it is somewhat of a absence of direction. I think that's a nice way to put it, don't you? So the item contents are supposed to be this: taking a patient history, what their barriers and enablers are to cessation. And by the way, when we first brought in the word cessation, people kept saying sensation. I don't know if you have heard that, smoking sensation, which is sort of an irony because these are words that we brought in the early 1980s. But now nicotine addiction is a given. I remember fighting to have that even as a concept in the 1980s. How do you assess nicotine addiction? Do you know how to do this? Do you know how to initiate an intervention or a referral? What's the management plan going to be? Your management plan. What's advice can you give to modify lifestyle factors? You will see within these itemised services these 5 components. However, there is no more detail than that. And I'm hoping tonight to show you some detail. How can we best manage our smokers? Explaining to them the pathway to smoking and cessation, what it's all about, why do people smoke, what's happening to them, why they've had such difficulty. And I hope tonight to address some myths and help you with some facts that you can pass on to them, because education makes a huge difference. I don't think I need to tell you that health literacy has a huge impact on our smokers, our clients, our patients. So this prevalence of smoking in Australia is really interesting. You probably know, I think, everybody who's travelled outside Australia will know straight away that we have a very low prevalence of smoking in this country. It has been tempered a little bit by COVID, perhaps a little rise because of the concerns people have and the distress they have around COVID. But we have one of the lowest smoking prevalences in the world, which is an interesting fact you should think about. So the question you want to ask is, how did that happen? We know it's expensive to smoke. In case you don't know this, you're looking at a brand like this one on your screen, might cost $45 to $50. Find out. This is a lot of money if people are doing 2 of these a day, every day. That's your pension gone. There's nowhere to smoke. There's obviously these graphic warnings on packaging, and there are social marketing campaigns for not smoking, as we've all seen. These things are all what's called the drip effect. Slowly but surely, people have gone down and down and down from smoking. Can't sell to minors. We've got all these rules and regulations that have hugely impacted on Australia and Australian smoking prevalence. And of course, heavily subsidized pharmacotherapies and lots of medical professionals saying things, asking about smoking. You know this, I suspect. I hope you do. The question is, why are people still doing it? Who is still smoking today? Are those who are highly dependent, who smoke in the face of what they know and evidently is not in their best interest. We're going to talk about that. Our Indigenous population around the world, this is common, mostly due to self-medicating, if we can put it very bluntly, post-traumatic stress disorder, social environment, very distressful. What they have in common, of course, is a lower socioeconomic status in amongst all these groups of people with mental health concerns, drug and alcohol comorbidities, diseases related to their smoking and still smoking. That defines an addict. If you didn't know that, that's the definition of an addict, is they do it anyway in the face of all of this. They've tried many times to stop and they're doing it anyway, and they have more stressors in their lives. Can I put it bluntly? Shit happens more. And that's true. You and I, if we have the wherewithal to manage our distressing and our finances, we can manage it. Many people, as you probably know full well, can't. They have more stressors. Their lives are more difficult. Do they find it hard to quit? We certainly know they do. And as I said earlier, I'm not big on the word quit, and I'll talk to you about that later. Quit using the word quit. They wake up in the morning and it's number one thing that they have to do. They've tried many, many times to not smoke. So we know most people don't really want to do it, but they do it anyway. About 3% of smokers don't want to smoke, don't want to quit, sorry. About 97% of smokers want to do something, want to manage their smoking. That we do know. So is there a problem with decision making? Why are they doing something they don't want to do anymore? I'm going to talk about that a bit tonight. They smoke in the face of using pharmacotherapies like NRT, nicotine replacement therapy. It's very common. We certainly have known right from the start of introduction of NRT, which was in the late 1980s. I remember getting the first gums in my hand, nicotine gum in my hand in the 1980s, and people smoking anyway. And you thought, why would they be doing that? And they're getting NRT. Why are they still smoking? And I'll explain that tonight as well. They've had really poor past history. It's been so difficult. They don't want to go there anymore. And that's not an uncommon history of a smoker. They're likely to be fast metabolizers of nicotine, which you may or may not have realized occurs. And why does that occur? There's a genetic determinant that doesn't get a lot of press that I'm going to talk about tonight as well. So many want to quit or stop doing it or manage it better, and some find it really harder than others. It's not a one size fits all. So their personal barriers, if we have to address that, what are your personal barriers? It's one of the items you need to sort of discuss and talk about. One of the personal barriers might be their actual addiction. They're not really choosing this as a lifestyle. I'm afraid that's not quite what addictions are. They don't have a lot of control. And in fact, their poor decision making, as I've got here at the bottom in red, and their inability to control it is what is a hallmark of addiction. An addiction is, I'm in the back of the car and I'm not driving, I'm not in the driver's seat. My addiction is in the driver's seat and I don't have a lot of control. That's quite a complex phenomenon that many smokers don't really know, who are dependent, really know that is what's happening to them. But it's worth our while to describe that to them. Their lack of ability to control this is really common. They have conflicting drivers. They enjoy this. They love it. They hate it. They have this conflicting imperatives. I should do something about it, but it's too hard. I've tried this before. I don't do very well. a lot of the work that I'm describing to you tonight has really good science to support it. You'll see at the end of tonight, I think I've got something like 40 citations, and I'm happy for you to look this all up because everything I say is evidence-based. For example, this inability to control yourself if you're addicted to something doesn't mean that, hey, it's not in my hands to do something about it, but it explains to the smoker why they've had such difficulty, why this is so tough, why it's been easy for one and difficult for another and hopelessly hard for me, or not. It depends. And so this range of dependency is what we've learnt about smokers. It's not a one size fits all at all. If they live in an environment where people around them are smoking, this is a real barrier. Using other substances is a barrier, but your familial arrangements, your home life, your friends, these have huge impacts on people's ability to be resilient, if that's the right word, against other people smoking. How do you do that? How do you manage other people around you? And we'll talk about that, who smoke, because this is a real risk factor for smoking and for relapsing to smoking. Some people look, it's too late, too little, too late. How many times have I heard I've got COPD and my doctor, or I've got emphysema and my doctor said it's too late, the damage is done, it's irreversible. And that's very demoralizing, of course, for anybody, but this language of irreversibility is really demoralizes me, because everybody's oxygen carrying capacity improves when they don't smoke. Everybody. And patients with emphysema, patients with COPD, with respiratory disease, cardiovascular disease, need every oxygen molecule that they can get. And because oxygen competes with carbon monoxide, if you remember that, then when they don't smoke, there's no carbon monoxide. And that's a real plus, a huge plus. So remember, everybody's oxygen carrying capacity improves. It's never too late to quit. The fact that family and friends, or GPs, and there's articles about all of this, as I said, nagging, saying, look, are you ready to quit? It's time you quit. Let's move on, time to quit. My husband doesn't want to quit. All this nagging of a smoker, unfortunately, can be really counterproductive. So how you ask a smoker about their smoking, how you address this actually matters. Are you ready to quit? If you know this impaired motivation and decision making is a hallmark of addiction, they'll never be ready. Keep that in mind. Or they might be today, but not tomorrow. Look up work by a wonderful presenter called Nora Volkow, who I cite at the end, who is head of the NIDA, the National Institute of Drug Abuse, who specialises in nicotine addiction from the United States. But look up her work about this vacillation, this indecisiveness, this corruption, that's the term, the corruption of decision-making in addicts and in nicotine addicts, the inability to really reconcile what they need to do and what they actually do. And how many times have you seen a patient who needs to not smoke but is doing it anyway? And they know full well, this is the description of what an addiction is. I'm sure you know what the DSM is, and this is it. And as I said, the criteria are fairly well described. I can show this to a smoker, and you could do this to actually show them, look, here's this definition of this. Does this apply to you? That you tried to not smoke and you get withdrawals from it. That when you smoke, it relieves your withdrawals. That you want to do this, but you don't actually succeed. It dominates what you're doing. Here's the definition of this. Look, it's in this medical textbook. And people actually don't know that. They have no idea that this has been a well-described, well-defined phenomenon. It does not apply to every smoker. Evidently not. If you want to say, this is like drinking and alcoholism. If you have a glass of wine with dinner occasionally, does that put you in the class of an alcoholic? Possibly not. What about the people who have to do this every day? There are definitions of alcohol dependence or alcoholism. This is the same. There are drinkers and alcoholics, and there are smokers and nicotine addicts. So keep that in mind. They're the people we're seeing more and more of every day. Show them the definition of this. It has an ICD code, but just show them that to allay their concerns that there's something particularly wrong with them, bizarre about them personally. As I said, there are levels of dependence. In this, just like drinking versus alcoholism, that's why I've got it up there. There's the mild dependent, the social smokers, the Friday nighters who only smoke with a drink. What does alcohol do? A whole lot of things I'm going to talk to you about tonight as well. That the Friday nighters only don't smoke at all during the week, only on Friday night, may not need medications to quit at all, or might, and I'll describe that too tonight. The moderately dependent who do it every day, but don't do it as they wake up, number one thing I need to do. They don't have this time to first cigarette is open my eyes and I need to smoke. Now they're a group of people who get a response to nicotine, have brain receptor responses to nicotine, but don't necessarily have that significant upregulation, and that's what it is, of nicotine acetylcholine receptors, as significant as the people who have it more severely. So it ranges, remember that. There's the daily who do it, and they're going to need medications for sure, who smoke within minutes of waking up. And can I suggest to you that you start looking at vapors doing the same? Time to first cigarette, time to first vape. We're now using that language. You can really adjust this to vaping. They smoke or vape despite the medical consequences or the negative components of it. They've had multiple attempts to not do it and don't do well. And if those who don't know this, nicotine addiction runs in families. There is a strong familial trait of this. And that's something we also like to describe to our smokers. This isn't to take the culpability out, put it out of my hands. It runs in my family. I'm nicotine addicted, therefore I'm out of control. I know. The idea is to explain why there have been so many difficulties for you as a smoker in the past, and now this is what we can do about it. This is how we're going to manage this better. So as I said, the tips for talking to smokers, in my view, in my clientele, the patients that I see, if they are told one more time to quit, they'll quit quitting. And that's fair enough too. I like to use the word manage it better. It's a better language to use. It's a lot less intimidating. We've been using this language with mental health smokers, with patients, with drug and alcohol patients who smoke. They like this word better, and we've actually even published on that. As I mentioned earlier, don't nag, because it really is counterproductive. Inform them about and educate them about the biological basis for this. What is going on with me? My partner stopped smoking, but I find it so difficult. I'm being told by everybody I know to not do this anymore, and I have little control over this. As I said, loss of autonomy is a significant sign of dependence, and you need to tell them that. Remember, I said it's not a one size fits all in medications, and we certainly now know to try different medications and combinations of medications. And don't say, look, you failed on this and you failed on that. They don't not encourage by saying failing. Let's just say, if you didn't do well that way, let's try this, rather than say this failed, because that again puts the onus of somehow failing on their part, which it obviously and very evidently is not. I mentioned that we're asking them things like, are you interested in quitting? I mentioned before, and that they vacillate, they have poor decision making, and their whole stages of change model are all over the place. So I like to put that somewhat aside and suggest other ways of addressing this. And as I said, they're certainly influenced by their past, usually terrible experiences, and that we're here to help them go transit from being a smoker to a non-smoker with as few relapses as we can possibly, or lapses as we can possibly have, and a smooth transition. We know if it's a drama, they're trying to not smoke and it's a drama, they'll relapse, they capitulate to it. And it's not because they're weak-willed, right, or they're choosing to do this, it really overwhelms them. The symptoms overwhelm them. So a little bit about nicotine, and I hope I'm not preaching to the converted, and I'm happy to be told you knew all of this. That's great. Do tell me if you knew all of this. In case you didn't know, and certainly our smokers don't know this, so educating them, nicotine's colourless and odourless. You don't smell it on your breath. It's not what makes your moustache yellow. It's colourless and odourless. It's the tar, the burning of organic leaves, like behind me, when they die and go old and you burn them, they will stain your fingers yellow as well. It's not nicotine. Most of the nicotine from a cigarette, for those who don't know this, is blown out into the air. 80% of what's in a cigarette is blown out into the air. And I have my little fake cigarette. This isn't a real one. It's plastic. Just to show you what happens is most smokers, remember, 80% goes in the air. They don't in any way get the whole dose of what's in a cigarette, because what's in a cigarette is lethal, but most of it goes in the air. And by the way, the same occurs with vaping. And you can see that, it's very evident. There's vape in the air, which also contains nicotine. So watch this space for passive vaping stories. But we know about passive smoking. We've all learnt about that. Just keep that in mind. It goes into your lungs through the respiratory tract, obviously. It's a very quick delivery mechanism for nicotine to go across the alveolar wall and straight into your arterial blood. Smokers love smoking because of it. That's how fast it is. And again, a quick aside about vaping. Vaping even better. Transit of nicotine across the alveolar wall into your arterial blood straight to your brain, bypasses the whole venous system. Now, smokers don't know anything about any of that. Unless they know some biology, you can explain it, why smoking and inhaling it is so good for them, why they like to get that positive reward that way. And then you don't get that with those nicotine replacement therapies that we use a lot, because it's nowhere near as quick. The delivery of nicotine from, say, nicotine patches is, and you'll hear me on this, lamentably low and lamentably slow. So there's not a patch addict on the planet. I've never come across one in my whole career. And as Darren mentioned earlier, I edit a journal, comes out of Cambridge, and I've never read one either. Very little patch addiction because it's so low and so slow. But this is so fast, and vaping so fast, that it becomes addictive. It delivers nicotine incredibly quickly through your respiratory tract, but not through your gut. Remind yourselves that we don't eat tobacco. We chew it. It can be up your nose, in your ear, not in your rear. But we get oral absorption of nicotine, hence chewing tobacco, hence nicotine replacements that are absorbed in the mouth. But if you swallow it, you get very little nicotine uptake through the gut at all, unless you're a very little person like a child. We can talk about that some other time. So the levels of the nicotine levels actually dictate to what people do. So if I'm not getting, as you probably all know this, a much nicotine from a weak cigarette, used to be called mild, remember, we can't do that anymore. Mild cigarette, you can't do that anymore. If you get not enough nicotine from a weak cigarette, you probably have all learnt, I hope, that you drag harder on this, right? And you hold your breath. Now, breath holding is really common amongst smokers. They don't know they're necessarily doing this. We measure carbon monoxide levels with smokers. And what we've learned from that is that when they smoke a weak cigarette, their carbon monoxide levels go up because they drag harder, or they smoke a weak vape, they drag harder. They compensate to allow the ability to really saturate their nicotine acetylcholine receptors. That's the aim of the game. Some people have more than others, as I mentioned before. What's interesting about this, if they don't smoke as many cigarettes a day, so they tell you, aren't I good? I'm terrific. I'm down to 5 a day, doc. Isn't that great? Or they tell me, Renee, I'm down to 5 a day. I'm so chuffed. And what they're doing is they're lurching from one to the next. Remember, if you don't know this, nicotine decays awfully quickly. It's a very short-acting drug. So they titrate their blood levels to the nanogram, not milligram, and I'll show you that in a second, what they do. But remembering that their aim is to get as much nicotine into the brain, and that's the receptor activity going on here, that saturates or floods that receptor with nicotine, and then it wears off. The problem is it wears off. Why have they done this? How can they do this? And perhaps you and I, in my family history, there's no smoking, there's no nicotine use. Okay, not because I knew what I was doing at 17 when I started, at the age when smokes were absolutely pitched at women of my age, young girls at my age. Tried a cigarette, it didn't do a thing for me. I don't have the capacity, it looks like I don't upregulate these nicotine, that's what they're called, or nicotinic acetylcholine receptors. That's what they're called. The natural ligand for that is acetylcholine, and it looks like nicotine usurps that acetylcholine receptor in the brains of some people really effectively. Basically means it takes over. It seems that this is an inherited trait. Have a look this up. Lots of citations about this. And it's dominant in the central part, the old reinforcing part of the brain, the hippocampus, the nucleus accumbens. These are the reinforcing parts of the brain. Some of you know about. I don't have time tonight to talk too much about that brain reinforcement, but I do tell smokers this because I tell them it's old brain. It's what's driving you to do this. You don't have a lot of control over. It's like saying, I'll never eat again. You get hungry. It's basically in the same part of the brain that says, I need to do this, otherwise I won't exist without it. And keep in mind, the upregulation of receptors in the brain are enhanced by the speed of delivery of the drug, in our case, nicotine, going through the respiratory tract into the arterial blood, bang to the brain, crosses the blood-brain barrier, which you understand, and which is really impressive. That's why nicotine in this case is so dependence producing, because it just gives you such a bang for your buck. And I just want to point out that kids get a big bang for their buck when they smoke. They get nicotine into their bloodstream, to their brain, and get a huge response. Not a small one, a big one. Sometimes we think, and there's good evidence of, you can have a look at that too, that their responses are bigger than older smokers who've developed somewhat of a tolerance and don't get as big a bang. What's impressive about this is because nicotine wears off so quickly, that speed of delivery enhances the response. It's complicated, but that's how it happens. Speed matters, which is why I said, low dose, slow delivery of nicotine with, say, those nicotine replacement therapies that we use. And remember, I don't work for the companies that make them. I'm not on their boards, and I don't take hospitality from them. But there's not really a lot of a speedy delivery of nicotine with those nicotine replacement products. This is just to show you how quickly nicotine decays. It doesn't last long. It's in the lungs. And I want to point out something that you may or may not. Look how long we've known this, since 1982. Did you know this? Nicotine in our plasma is in nanograms. It's not in milligrams. Though you might smoke a cigarette that's in milligrams, the blood levels are in nanograms. I mentioned before, most of it goes out in the air, then it's in your bloodstream, then it's diluted by your lung volume, then your blood volume. By the time it's in your arteries and in your brain, it's hugely diluted down to nanograms. Please keep that in mind because it matters. NRT, our nicotine replacement therapies, also deliver blood levels or plasma levels in nanograms, not milligrams. So your famous 21 milligram patch doesn't give you 21 milligrams of nicotine. Please know that. Please know that by the end of the 24 hours, most of the nicotine's in the garbage when you take the patch off. You need a gradient. You need nicotine going across the skin to allow even a small amount of nicotine into our bloodstream. So a big problem we have, just to point out to you right now up front, we don't have enough nicotine replacement. It's not doing it for those smokers that we are now managing. So the salient features of this slide is the blood levels are in nanograms and the fact that it wears off so quickly. Look at this half-life. Nicotine has a half-life of between 40 and 120 minutes, depending how fast you personally or your smoker metabolizes nicotine. Just like alcohol, you know how alcohol can be. If you have not a lot of alcohol dehydrogenase, my hands up here, I don't tolerate alcohol very well. I can't excrete it very well. Hence, it circulates longer. People understand that. The same happens with nicotine. It circulates longer in people who do not metabolize nicotine quickly. I mentioned earlier, fast metabolizers excrete nicotine really quickly, and then they need to do it again. And then they need to do it again. And that's when numbers per day start to count. Because if you're excreting this quickly and you're a fast metabolizer of nicotine, then you're going to need to do it about every 40 or so minutes. So if you know smokers who are doing that, don't go down the line, oh gosh, they've got a stressful life and they're doing this. Think liver function if you can before you think life and environment. And I'm going to talk a little bit more about that too, because it matters. But I do want to remind you that cigarettes are packaged 25 in a packet according to the half-life of nicotine. This is not, gosh, arbitrary that they're in a packet of cigarettes has got 25 in it. Think of your waking day, 18-hour waking day, divided by the half-life of nicotine. Hey, guess what? You get 25 in a packet. Now, smokers have no idea about that. And they really do feel that they're being had once you inform them of that. Just a small bit of information that's really telling. And they don't know that. How would they know that? But we do, and we inform them of that. This is what nicotine does. It acts, I'm sure you know, as a conduit. That's really, it affects these neurotransmitter. It's a gateway, that's how you want to put it, to the expression of these substances. And why I've got this up, and again, this is an old slide, really very old, of one of the researchers I mentioned earlier, or I have cited earlier, Neil Benowitz in the 1980s, who's still doing this work on dopamine, noradrenaline, acetylcholine, vasopressin, serotonin, beta endorphins. Remember, these are products that you make endogenously. A beta endorphin is endogenous morphine. And why I've got this up is this is the pleasurable effects people get from smoking. And if we don't know this and don't acknowledge it, we can't help our smokers. They feel it makes them relaxed, it modulates their mood, it improves their memory, it improves their cognitive abilities. Read up Sigmund Freud about how he smoked his cigars to improve his cognitive abilities. He wrote a whole tract. This is in 1920 about that. So if we know this and we're trying to help our smokers, we need to remember the pleasurable effects so we're up against it. These are the pleasurable effects they get from smoking. And this is what happens when they try to not do it, right? And these withdrawals, I'm mentioning this here to you, these withdrawals are well described decades ago. This is not something new. So there's been some myths out there about smoking cessation products like varenicline, which I'm sure you know we currently have a problem getting, that these are side effects of the medication. Don't go there. We've known this for decades, that the side effects of not smoking are substantial. Nicotine has these effects on the brain, which may, when you take it away, cause obviously urges to smoke. And remember, an urge to smoke is a symptom of withdrawal. I need a cigarette, I'm dying for a cigarette, and it's been half an hour. Remember, this can happen between cigarettes. It's been 2 hours since I've vaped or 2 hours since I've smoked. People have these symptoms already. They're hungry, they're aggro. Aggro doesn't get a lot of press, and it should. They're anxious. So we've been able to measure these symptoms. I want you to be mindful of the fact, phenomena like depression, like even clinical depression in people when they try to not smoke. So we always keep our eye on mood. How's your mood? Because we think potentially some of our smokers, and we understand about half our smokers out there today, might have a component of mental health concerns like depression that they're masking by smoking. Keep your eye on mood, I always do. Mouth ulcers, abscess stomatitis, is a common phenomenon in smokers who quit. 1 in 3 smokers, we measured this years ago, get mouth ulcers when they try to stop smoking. And people think, what has this got to do with anything? Well, it has. Obviously, there's an event. These mouth ulcers, abscess stomatitis, as you know, is not infectious. It has some relationship with the stressful event of not smoking. Constipation is a common symptom of withdrawal, not always volunteered by our smokers, but we certainly know it can drive people back to smoking. So people capitulate to these. I'm so constipated, I'm so low, I can't sleep, I can't concentrate. People have some of this or all of this, and I've got cough there. If you haven't remembered that, remember that nicotine is a cough suppressant. Nicotine suppresses your cough. Look that one up, which is why once upon a time there was a GP in Bondi Junction who had a plaque up saying, if you're an asthmatic, you're welcome to cough and you're welcome to smoke, which is what? You're welcome to smoke if you're an asthmatic. If you're coughing smoke, it suppresses your cough. He was right, but not for the right reasons, because what happens eventually is they'll go on to chronic respiratory disease. But does nicotine suppress your cough? Yes, it does. So it's such an interesting phenomenon. So if you have smokers who stop smoking, they then develop a productive cough and complain about that, which we, of course, some of you might know, say that's a good thing. It's a good sign your cough reflex is coming back. Yay for that. Good thing to have. So the time frame of withdrawals is really interesting. We know that the first 2 weeks of making a quit attempt can make it or break it. 62% of people relapse within the first 2 weeks of saying, I promise I'll never do it again. This is people getting no help. If we're helping them, we're going to have to do something in the first 2 weeks. So if you just put up your hand and said, I'm not going to smoke ever again, and you put your hand up, within 2 weeks, most of them have gone back to doing it, a good majority. Then certainly by the next 2 weeks, the rest of them. So a good majority of people capitulate to withdrawals. So we are here to help them, obviously, in the first few weeks. It really makes it or breaks it. And as I said, don't confuse nicotine withdrawals with nicotine toxicity or with overdose or nicotine. You know, I'm so agitated by, this is a common complaint, I'm using NRT and I'm terribly agitated, I'm overdosed. I'm agitated, I'm distressed, I'm aggro, I'm overdosing, and it's usually underdosing, the reverse. These are symptoms of withdrawal, which people then confuse with toxicity or a side effect of the medication, and they're usually wrong. And reminding yourselves that nicotine toxicity and nicotine overdose are extremely rare. extremely rare. Can you be dispatched wearing patches all over your body? And I would say to people, if I put a patch all over my body, all I'll feel is yuck, probably a bit nauseated, more than just a bit nauseated, very nauseated. Will it kill me? Definitely not. Remember, the blood levels are in nanograms. I want to put a caveat on this: nicotine toxicity and overdose are extremely rare now, because very recently, in the last, say, 6 months, we're seeing it in adolescents who vape. We're seeing kids do really poorly with, unfortunately, they are getting signs and symptoms of nicotine overdose that we don't see in adults. They have no tolerance to it. They're sort of nick sick is the term, but that's for another night for me to tell you about. But we don't really see it in adults. Don't worry about nicotine overdose in adults. The role of the liver in smoking doesn't get a lot of press, but I'm going to tell you about it now. And that's because it has such an impact on our smokers. And I mentioned that it is genetically determined. How you metabolize nicotine, break it down, how you metabolize it depends on that liver enzyme type. The P450 CYP2A6 does nicotine, and that one has about 12 variants to it, CYP2A6. So there's weaker and stronger variants to it. So those who are, again, it's an inherited trait. If you're a fast metabolizer, you're certainly more prone to be addicted to it because it gives you that shot of nicotine that wears off. Up, down, up, down. So shots that wear off stimulate nicotine upregulating receptors, unfortunately. That's a dilemma. And because it wears off and because they have to smoke, in this case, more cigarettes to maintain this blood level of nicotine, smoking and lung cancer, I'm sure you now know, is a numbers game. The more you do of them over your lifespan, the higher the risk of lung cancer. So I want you to know that. But it also has got to do with the fact that you've got to drag harder. You've got to inhale more particulate matter, more carbon monoxide, more nicotine. You've got to inhale deeper. And remember, they crave a cigarette first up. It's number one thing. The time to first cigarette is really on waking. I wake up. Remember, overnight, your nicotine has been metabolized. It's cotinine, that's its metabolite, and that you excrete in your urine or your saliva, and you're excreting it really quickly. So you wake up in the morning with next to no nicotine in your bloodstream, and so that's why you've got to do this to be able to, frankly, function. People say, I can't get up, I can't mobilize myself, I can't concentrate, I can't think straight. Have some nicotine and I'm off and running. So the slow metabolizers are less addicted, have a lower risk of lung cancer, don't inhale as deeply, they're not as desperate for a cigarette on waking up, and they do better on NRT. They do better. Our fast metabolizers don't do well on one form of NRT. And now you know, if you've got, this is a flag for you, if you've had a patient say, look, those NRTs, they don't work, I smoked as well, and I was scared about that. Now you know why. They were not getting enough NRT, not enough. That has been a major problem we've had almost since the inception with this category of smokers. I want to remind you there are other things that affect nicotine liver metabolism. Ethnicity is one of them. Again, I don't have a long time to talk to you about that, but just so you're aware, the whole of the Mediterranean rim, folks who come from the Southern Europe, think the Middle East, think of your patients from the Middle East. Do they smoke like it's going out of style? Yep. The Turks are well documented fast metabolizers of nicotine. So there's groups of people who excrete nicotine quickly. It's an inherited trait and have a higher risk of lung cancer, which is really interesting. Asians, Southeast Asia, lower not as fast. That doesn't mean the prevalence is lower, if they just don't excrete nicotine as quickly. So they don't have as many numbers per day. Just pointing this out. So your ethnicity actually matters. Various things affect hepatic function. I don't think I need to tell you. If it increases after a meal, is that why you need to smoke after a meal? There's a whole good lot of reasons why you need to smoke after a meal, and that's one of them. Just be aware that grapefruit juice, as you probably know, inhibits 2A6. So can we recommend those who can have grapefruit juice as a treatment for smoking cessation? There are papers on that. As you get older, maybe you don't smoke as much. You just, your ability to excrete nicotine isn't as great. Is that why young kids are excreting nicotine? I'm talking 14-year-olds here. Young kids are getting rid of it really quickly, so they get a shot of nicotine and excrete it really quickly. They said neurologically they get a bang for their buck from the brain responses to nicotine, and metabolically it's different for them too. So neonates have reduced metabolism. The whole perinatal period is fraught with the, unfortunately, with exposure to nicotine right from pregnancy into childbirth. Nicotine stays longer in the neonate. Nicotine passes through the breast milk to the mum, to the bub, and bubs, as you probably know with other things, don't really metabolize nicotine very well because they're got a baby's liver and have higher levels of nicotine than the mum, which is really quite horrific if you know what the effects of nicotine on the developing brain is. And it's really substantial, not just on the developing bub, as you know about, but on the bub's brain. Huge impacts on bub's development, mental health. So other enzyme effects that you probably know about, I'm suspecting that you do. Look at the medications that are involved with smoking. When you smoke, for those who don't know this, when you smoke anything organic, leaves like behind me, leaves of any type, think cannabis is a leaf, you're smoking, you produce what I call polycyclic aromatic hydrocarbons. Now you know them as the charcoal on your steak, which you know you're not supposed to actually eat a lot of, but they also do this trick called induction. And so when you inhale them in a gas phase, like you do when you smoke, and there are some PAHs in vape as well, you induce 1A2, these liver enzymes, 1A2 and 2D6. And they're the ones that you probably know about that metabolize many medications. Probably the best one that you know, I suspect, would be the antipsychotics. But not everybody knows that anticoagulants are affected by this too, as well, that painkillers are affected like this, anesthetics are affected. There's a whole screed of medications. Did you know that? Methadone is affected by this. So a smoker who's on methadone will need more methadone when they're smoking because they're a smoker of any green leaf, any organic material. And when they stop, they need to have their methadone adjusted. So we've had cases of methadone toxicity, of anticoagulant like warfarin toxicity, unexplained bleeding in people who've stopped smoking, but their warfarin levels have remained, that is, their intake, their warfarin medications have remained the same. It's the same with antipsychotics, you've probably heard that. The one with caffeine is one particularly important and interesting to me because many, many smokers drink a lot of caffeinated drinks. And it's not just coffee, cappuccino in one hand and a cigarette in the other. It's Coca-Cola, it's Red Bull, it's the energy drinks. Think of your cannabis users. They make a bong out of their Coca-Cola bottles. That's how much Coca-Cola they use. They use a lot of caffeinated drinks. And what they don't realize is that when they try to not use these not smoke anymore, not smoke cannabis anymore, they can become quite caffeine toxic. And that's a repercussion that they don't understand. Why? Since I've stopped smoking, I've got the jitters, and that's not an uncommon side effect. I've got the jitters because I'm now getting twice as much caffeine than I used to get. And people don't realize that, and we always ask about caffeine intake. Remember, this is not a nicotine effect. So beware when people are acutely hospitalized. So going along swimmingly on warfarin or on their antipsychotics or on their methadone, everything's okay. They're acutely hospitalized for something, and you're not allowed to smoke. And when you're not allowed to smoke, and we put you on nicotine replacement therapy, as we should do and do in hospitalized patients, that's what we're doing. What's happening, they've got no PAHs suddenly. And so what then happens is the warfarin, the antipsychotic, the methadone, it starts to go up. And this is within 30 hours, less than 30 hours. Have a look this up. Please be aware that within 24 hours, all their levels are starting to change dramatically. Even when people convert to vaping, it hasn't been mentioned. I know it, I know about this, but it hasn't been mentioned that if you're not getting PAHs, you need to adjust their medications if they're vaping, because there are very few polycyclic aromatic hydrocarbons with vaping. So medications need adjusting as well. What do we need to do? Always talk about these. Can you talk about PAHs? Possibly you could. And these enzyme inductions are quick. And what's called enzyme repression is quick. And reminding them, they don't have to stop coffee. We don't want them to stop caffeine, but we want them to know that whatever they're taking is stronger when they don't smoke. Now, we take advantage of that with, for example, medications. You don't need to take as many medications. This has been recommended, say, with cancer patients. Don't have to take as many cancer medications or HIV/AIDS medications. This is all correct and true. You won't need to take as many pills, which is a great thing to know. Alcohol, by the way, is heavily affected by alcohol dehydrogenase, which is in itself induced by both PAHs and nicotine. And nicotine does this. So that's a very interesting effect. In other words, smokers drink 3 or 4 times more than non-smokers, which is why the pubs and clubs always have a place for you to smoke, because if you don't have a place to smoke, you're not going to drink as much. It dramatically affects blood alcohol levels. Smoking dramatically affects blood alcohol levels, and it can lower it dramatically. Just be aware of that. Smoking can lower blood alcohol levels dramatically. Now, if you know that and you're a smoker and trying to not smoke, what happens to your blood alcohol levels is they go up. And when they go up, you're a cheap drunk, effectively. Just be aware of that. But also, you don't have to spend as much money on alcohol, which is a sort of an interesting side effect, if you like, of not smoking that doesn't also get a lot of press. But smokers know that. When they've quit, people who've quit a long time say, I can't hold my alcohol as well as I used to. I don't need to drink as much. It's maybe they think it's to do with the conviviality. You know, this is a glass of water, by the way. Cigarette in one hand, alcohol in the other, alcohol in, or a cup of coffee in one hand and a cigarette in the other. These are common things that have gone together. Have you noticed that? These are not just any old thing. This is not going to be an orange juice and a cigarette. Gosh, you know, love a cigarette with an orange juice. They don't. People don't. These things are universal. Alcohol and caffeine are universal. And that's because they have 2 distinct effects on liver function and also on the brain, that alcohol and nicotine stimulate together, have synergistic effects on the stimulating areas of the brain, as do caffeine and nicotine. So you do keep that in mind. They don't go together for arbitrary reasons that are social. They're actually physiological, and that's why people love to do them together and have developed those cues that have conditioned them once they have a drink to have a cigarette. How do we go about assessing a smoker? I mentioned, time to first cigarette. And I always want to remind you to ask them what they're smoking, about the brands they're smoking. Don't just ask, do you smoke, but what are you smoking? Are you smoking roll your owns? There's a myth that roll your owns are better for you, that weaker brands are better for you. Isn't it better I'm smoking a weaker brand? Roll your own is very much like weaker brands. People drag harder on them when they roll their own. Not only is it not better for you, it's worse for you. I just want you to know that. They're worse for you because you drag harder on them. So debunk that myth, please. Talk to them about their previous attempts, their so-called pharmacological failures, which we don't use that word, but what happened to them? Talk to them about family history. If you have an inherited trait to respond to nicotine, you're going to always have that. So it really does mean, like alcoholism, if you like, take that on board. It means you react to nicotine differently to other people. And I want people to know that. Our smokers don't know that. Why me? Why have I got this problem and my partner doesn't have it, or my friends, they just quit like that and I'm so weak, I can't. I find it too hard. Talk about the inherited traits of this. Talk about their environmental context, people smoking around them, and how important those risks are when they're breathing in other people's cigarette smoke. Ask them about their environmental context, because we're going to take that on board and help them manage that better. I mentioned their medical history. Psychiatric patients in particular have higher blood levels of nicotine than non-psychiatric patients or drug and alcohol patients. We talked about fast metabolizing. We talked about mental health and pregnancy. Their medication's absolutely essential. And the fact that they're daily smoking, and talk about why some do more than others. And this is an interesting one. This is called the stress paradox, if you haven't heard that before, and I said that right earlier in the beginning. I have a stressful life, lots of stuff happens to me, and that's why I smoke, to relieve it. And does it relieve their anxiety acutely? Sure it does. So we need to tell them nicotine has an acute anxiolytic effect. Absolutely true. But the problem is that it wears off. It wears off incredibly quickly. And that's why I said, think about how many are in a packet a day and why they do this. It wears off so quickly. And that becomes what's called that stress paradox, because when it wears off, they become more again anxious and again depressed, which is part of withdrawals. Remember, withdrawals between cigarettes. Have a cigarette, makes me feel better, and then it wears off again. And they're in that cycle, and this is called that stress paradox. And it's nicotine that's doing all this. Once they're out, nicotine's out of their lives, and I can really attest to this with so many thousands of smokers we've seen with mental health concerns, with drug and alcohol problems, the people who are really still smoking in the face of their medical consequences. All of that is gone. They're a much more relaxed, calmer, and a great deal less anxious, and their mental health has improved so much. So don't go down that line thinking this is not going to improve their mental health. It does. Absolutely good evidence for that. If we give them our time and we help them with this. I've talked a little bit about assessing dependence. You can all have copies of all this assessment. We've got questions we know to ask them. And I'm happy to share a questionnaire with you. If that's what you'd like, let me know. My own standard questionnaire. How do we initiate treatment is what we're coming on to next, and what sort of monitoring we would do. So we know pharmacotherapies make a huge difference. I know you heard the story doubles your chances of quitting, but it really does. And if we do this well, we can hugely improve their chances of quitting or managing their smoking better. And it makes a very big difference. It made all the difference to me when I got pharmacotherapies that I could recommend to smokers and recommend doctors prescribe to smokers. This is the important issues that I mentioned before. There's no real good evidence that cutting down helps. It just makes everyone a peak, unless you cut down to quit, and that's it. But cutting down, what normally happens when people have less of them, they smoke them differently, and it may be worse. So it's not a really great idea, which is very hard to impart to a smoker. We know that weaker and milder cigarettes are not recommended. They certainly are worse for you because smokers compensate. So it's the compensatory smoking for both issues of cutting down and weaker and milder cigarettes that hence we can't recommend either of them. And I want to remind you that there's no good evidence for hypnotherapy, acupuncture, laser acupuncture, and lots of creams and lotions and potions and snake oil that's out there, I'm afraid, that with unsubstantiated claims of nicotine coming out of the pores of your skin, the soles of your feet. I've seen it all. There's no evidence for this, and we couldn't recommend it. There's really, it's not recommended by us in health at all. It's unconscionable to do that. Important issues where there's good evidence for this is combination treatments for with NRTs, the fact that there's no overdose with NRTs. I mentioned earlier, can you put patches all over my body? Yes, you can. If it helps me with withdrawals, we can do that, and we do that. And there's no evidence for overdose, no side effects or toxicity with too much NRT. We certainly know that there's good evidence for the longer you use pharmacotherapy, the better. What I'd like to see is smokers using it at least 6 months, at least. These are our smokers who've had real trouble, remember. These are the harder to treat, if there's such a thing, right? These are the people in that group that we want to do really a lot better with. And we can do this. If we give them pharmacotherapies, don't give them a deadline, you've got to stop by 3 months. No. Longer is actually better. And why is it better? They're learning, if that's the light, learning how to behave, in inverted commas, without smoking. So life goes on, shit happens, if you don't mind my English here, and they're learning to behave without smoking when these things occur, when stressful events occur, when triggers to smoke occur, when stimuli, people, coffee, alcohol, various other things that are stimuli to smoke occur, their NRT keeps them buoyant, keeps them from relapsing. And we've known that for a long time. So keep it up for longer is fine. It doesn't matter. It does them absolutely no harm. We've talked about varenicline, and I can briefly now tell you that it looks like varenicline might come back as a generic. It certainly has now been approved by the TGA, not by Australian TGA, sorry, by the FDA in the United States. So watch this space for varenicline coming to Australia in another form. It won't be Champix. And I'm happy to talk about that later tonight as well. But there's also good evidence for combining varenicline or Champix and NRT if needed. And combinations do much better than single uses. So we're combining more NRT, lots of it. I'm not going to really talk tonight too much about e-cigarettes. I have a little bit about vaping. By the way, the word vape has come up as an invention of the tobacco industry to get away from the word cigarette, which has had a lot of bad press. They invented the word vape so that you're vaping and not smoking a cigarette, which has got bad press. What's the right pharmacotherapy for my patient? How do I know what they should be on? Get an idea from their past use of something. I didn't do well. I tried Champix, it didn't work. I tried NRT, it didn't work. Tease out, what do you mean by that? Were you on the right dose? Did you get enough of it? Did you use it for long enough? Were you using these things properly? And most of the time they weren't. And I do want to suggest that there are familial traits in treatment outcomes. So there are papers on that. Some, it looks like, familial traits to responding to varenicline or Champix and to bupropion or for those who don't know that, I'm going to come to it in a second. How you, it looks like there are familial traits. How you metabolize Zyban or bupropion matters as well. Are there cost concerns? Because there's many, if we're telling you to use many NRTs, they're not all on the PBS, which is quite upsetting and difficult for our clients or patients who are going to need a lot more NRTs than are PBS subsidised. That's difficult because they are in a very specific category and we'd like to see them, and that includes pregnant women who also need more NRT. We'd like to see them heavily subsidised by this. This isn't a choice our patients are making. And what are the contraindications? Are there any at all? There's not a lot in most of the medications we're recommending, if any. What about then if they're not daily smokers? What are we going to do with them? And I mentioned, do we use NRT? Believe it or not, we do. Friday nighters, a little bit of NRT, put a patch on, here's a tip, put a patch on in the morning if you need to smoke at the pub on Friday night when you're drinking with your mates. And I don't want to give that up. Put a patch on in the morning, just one day a week. It does the trick. I've seen it and done it. So I mentioned before, no evidence to support the miracle cures. If you've heard about them, there's really none. You know, I think I mentioned this earlier, so I'll keep going. But what we do know is first line evidence for these treatments, combining treatments looks like a better outcome combining. So we talked about I talked about double your chances of quitting. I'm now suggesting to you that you could do far, far better if you can quadruple your chances of quitting if you combine treatments. So think of adding things to people who are smoking a bit while they're on this. I'm on NRT, but I'm still smoking, add more. I'm on varenicline and still smoking, add more, add NRT to the varenicline. You can do this. Good articles to support this, good evidence to support Zyban plus. So don't just think one, and it can make or break an outcome. We've done this with NRT, 2 patches, much better than 1. 3 patches, much better than 2. Just keep adding them, and it really absolutely shocks and surprises, very pleasantly surprises a smoker who on 1 didn't do well and on 2 does brilliantly. Just adding another one. And it's not rocket science. I'm going to show you an algorithm I've written and published years ago that you can do this and add it. And some of you might know this is in our flow charts in New South Wales Health. We have a thing called the tobacco toolkit, and it's in the tobacco toolkit, this algorithm. So always happy to talk to you in depth about all of this. I'm just pointing out here, we've talked a little bit about varenicline not being available currently for a gamut of reasons, but watch this space for a product called cytosine, which might be coming on the market, we hope. In Australia, it's a plant-based treatment, which is the origin. Varenicline was based on cytosine. So look cytosine up. There's a Cochrane review of it. Can you recommend it today? You can't get it in Australia. However, you can legally buy this online. It is freely available over the counter across the world. This is a non-prescribed substance. But watch this space for cytosine coming up. As I said, combinations are very effective, and combinations of varenicline and we might see in the future cytosine plus NRT. Why not? Remember, our agenda here is to save these people, our smokers' lives. That's our agenda, bottom line. This is just a little bit about NRT. I mentioned no evidence for overdosing. Longer, better. TGA has approved its use for pregnancy. It's safe, of course, than smoking in pregnancy. There's no contraindications. We now are very happy to use it and recommend it. No serious side effects. I'm personally happy to put a patch on somebody and suggest a patch and recommend that you doctors prescribe patches, because it's just so easy. You just put it on. It doesn't require you having to take a lot of oral NRT, which can sometimes be tedious, especially if you've got to do it 15 times a day on a sheet, you know, and sometimes you do need to take it, a lot of it, not a little bit. There's this, as I said, a particular underdosing of these NRT products, which has been our problem for a long time, underdosing. And we don't need to wean people off, don't need to wean them off at all. I have just a slide we've been showing for years just about the doses of these things and how long it takes these nicotine products to actually work. So for example, if we know, and this is slow, remember this is in nanograms, the plasma levels of nicotine are in nanograms, and that includes your patches, your gums. The 4 milligram gum, just to give you an idea, gives you 10 nanograms, not 4 milligrams. This is the blood levels of nicotine. If you care to look, when most people haven't, look how slow and low and how long it takes. This is 2 hours to achieve a blood level of nicotine, nowhere near what our smokers are getting. And our smokers, the ones who are the more difficult, if you want to call them recalcitrant, I don't really, they've got blood levels up here, 40, they're up 35 to 40 or even 80 nanograms. Well, one patch is obviously not going to do it for them. No wonder they smoke while they're wearing them. So don't be fussed or concerned they're going to overdose. If 2 gets you closer to what you got from a cigarette, then it's 2. And if it's 3, or as my colleague Karen Counter, who is an expert on doing this, Dr. Karen Counter will suggest 4 or 5, whatever it takes to get you to that level where you feel like you don't feel like smoking it anymore, and that's the level you're on. And that's true, exactly like that. So I said avoid underdosing. Most of our smokers need more than one single form. Use combinations. Patch at night. This is one thing we've learned, because those patches, for example, take so long to work. I suggest, and we've got that out in our algorithms, that you put it on just before you go to sleep at night. And this business about, oh, I can't sleep at night with patches. Think caffeine. Remember the caffeine levels. Keep them awake at night. Always ask about caffeine, but reminding yourselves that if you put a patch on just before you go to sleep at night, you wake up in the morning a lot less urge to smoke. You're giving yourself a start off to change that time to first cigarette. And we've been doing that for many years. We do measure carbon monoxide. It's a great motivator. I've written a lot about this because, and a carbon monoxide machine costs about $600. Why it's worthwhile doing if you see a lot of smokers is a huge motivator to see the changes. It does provide fabulous biofeedback, and it helps us, it's not rocket science, to literally adjust the dose of NRT that they require. And as I said earlier, don't stop NRT too early, go on for many months. It's fine. Let them learn how to behave without smoking. This is the algorithm I was speaking about earlier that shows you how to add NRTs if you need to. This is NRT to start off with a patch, putting it on at night. If they don't smoke, that's fine, and continue it for many months. If they do smoke with a patch on, that's fine. frankly, wearing or using NRT reduces the impact, and that's pretty straightforward to understand, that smoking on top isn't as reinforcing. So some of the time, are you ready for this? I tell the smoker, you know what? If you want to smoke, fine, put a patch on and smoke anyway. It's okay. It's not going to do you any harm. You've been doing this anyway. But what I know is if you're wearing a patch or you're using a gum, and our TGA's approved this, right? A gum and then a cigarette, a gum, and then in that order, it will make that cigarette less reinforcing. So that's a little tip. Alternate. You can do that. But this little algorithm will show you how to adjust, how to add NRT. And the idea is when there's CO readings, and this is why I use CO, but you can use time to first cigarette, TTFC, or TTF V, time to first vape. If you add NRT, it changes the dynamics. They don't need a cigarette. The urgency goes down. They might want to smoke, but it's not as urgent. And that's the whole issue. They're not dragging hard on it. Their CO readings will go down. We can show them that. Or their time to figure, for cigarettes has been delayed. Automatically, they're not pressured, or the urgency is gone, which is really ideal. So you're welcome to copy this and use it anytime. These are the so-called, our form of harm reduction strategy is to use NRT and smoke at the same time. As I said, alternate use of NRTs, a vape and a cigarette. You want to smoke, fine, have a vape and then, sorry, not a vape, the nicotine oral spray and then a cigarette in that order. Because the uptakes of these, unlike a vape, are oral absorbed and they're not as reinforcing. And that's the trick here, not as reinforcing. So if you use an oral gum and then you smoke on top of that, it makes the cigarette less pleasurable. And as I said, using patches prior to quitting is quite well established now. And what happens to a smoker when they're doing this? They notice, gosh, I don't need to smoke as much as what I used to. I'm a lot less compelled to do this. I'm smoking, but I've got better autonomy. I've got better control over this. And this is something that we'd like to see happen with them. So it's not, I'm going to quit on Monday. We haven't picked a quit date. We haven't said on Monday, that's it, done. We're doing this slowly. And what's really interesting about this strategy is that our smokers really like it. There's none of this, imperative. Pick a quit date, you must quit. So I said, if the language has changed, how about we manage it better like this? So these are for our more difficult cases who find it difficult to even conceive of the idea of not smoking. So a little bit about, as I said, a little bit more about managing it better. We know that they down-regulate receptors when you do these slow NRTs. They down-regulate receptors. We don't want to we don't want that shot of nicotine to the brain, which up-regulates receptors, which we are afraid, and we'll see what happens with vaping, that might do it because it's a shot of nicotine that wears off very quickly. And we certainly know after cessation, smokers are a lot less agitated, a lot less reactive to stressors. That's when they're nicotine free. Remember, nicotine free is what you want. A little bit about varenicline, though it's currently not available as readily to us at the moment. And this is just a little bit about the safety of it, because sort of need to talk about it. The safety of varenicline has been, unfortunately, there's been some bad press. And keep in mind, agitation, aggression, depression, even suicide ideation has been well known to occur in people who stop smoking way before the advent of varenicline, way before we ever had it. We've seen these things. So I just want you to have a look at Cochrane reviews over this, many studies now showing the safety of varenicline. Don't assign these with what we know as being nicotine withdrawals as a side effect of varenicline. They're nicotine withdrawals. So if we have people who present with depression, anxiety, agitation, and mood changes, who are on but are not smoking, add NRT. Add NRT. Don't take them off the varenicline. Add NRT to it, and everything will change. Good evidence to say what I'm to support what I'm saying. So please reconsider taking them off something when it is partially working. Remember, it's a partial agonist, partial antagonist. So NRT, along with this, actually does have an impact. Bupropion or Zyban, as you probably know, was originally an antidepressant, is still available. It's not a first-line treatment. We don't use it a lot because it does have cardiovascular effects, and it does change, not so much cardiovascular, more to do with brain effects that changes the seizure threshold. So there are contraindications. It used to be called Wellbutrin, and for those who don't know that, but it's metabolized by 2B6. And if you don't have, or if you're not born with the right allele or component of 2B6, unfortunately, the right type, you will not metabolize it to its active ingredient, which is hydroxybupropion. And some people just don't do that. And this is a familial trait. So if people don't do well on Zyban, my husband did really well, and hopefully you're not genetically related, but if you aren't, you just may not be able to metabolize it correctly to its active ingredient. And that can happen and is not well known about bupropion. We don't use it widely, and it's certainly not as good as varenicline. Or, as I said, watch your space for varenicline becoming cytosine and possibly us having a generic type of varenicline sometime in the near future. Just for follow-up, what we do for follow-up with our smokers is intensively in the first 2 weeks. As I said, that's the relapse time. We always treat their symptoms. We like to treat their symptoms so that we try to get them from smoking to not smoking really smoothly. We always ask about time to first cigarette. How soon now after you wake do you smoke? So you're on NRT. Is there any difference? On varenicline, the same. It delays the time to first cigarette, so it helps you to know you're on the right track. We ask about mood changes. What about behavioural changes, which I'm going to just quickly mention to you? I know I'm going way over time because there's a lot to talk about. Inquire about exposure to other people's smoke. So as I mentioned about other people smoking, that is has a huge impact. So what are we going to do about these sort of behavioural, education and behavioural and relapse prevention? What are we going to tell them? How are we going to change them, counsel them on their lifestyle modifications? That's one of those criteria, the 5 that I showed you, you're supposed to cover in all of this. We know that counselling one-on-one is much better than self-help material, than pamphleteering, than even in a group. We know that one-on-one, obviously, if we can do this, if we frankly individualise the treatment, the outcomes are so much better. We know that one-on-one is so much better. So always smoke outside. You smoke, they smoke, your friends smoke, you smoke, everybody out. This is, we know, a gateway to quitting. So talking about how do we manage this? Everybody smokes outside, new house rule. If that can't be implemented because, somebody says, this is my home, this is my castle, bugger off, I'm not leaving, you leave. The person who's trying to not smoke goes away from the active, passive smoking. Don't be an active, passive smoker. The effects on you, breathing in somebody else's smoke, the cues, the stimuli to smoke are substantial. Separate reinforcing cues like the drink in one hand and the cigarette in the other, the cup of coffee in one hand and the cigarette in the other. Smoke outside, pull apart those reinforcing cues. Smoke your cigarettes outside and have your coffee inside. Keep that in mind. Always separate my mobile phone and a cigarette, separate them. Have your mobile phone, have your coffee, just don't do them together. Smoke, and you know, with smoking, friends socialise where you meet your friends where you can't smoke. And that's, in Australia, we're very lucky for that. There are many places we can socialise in non-smoking areas, which is a real fortunate thing for all of us, because you can meet friends and colleagues and, you know, you're not stimulated. These are some little tips that we've learnt about managing cues or urges to smoke in people who can't. Like, I can't go outside, I can't, because I'm in lockdown and I can't smoke inside because I don't smoke inside. What can I do? Well, these are little things. NRT helps. I've told you about that. Short exercise help. There's evidence for this, like press-ups, or even running up and down a step for 1 minute, a 1 minuter. Mimics the effect of nicotine, which is very interesting. So there are some things that we know mimic nicotine, like jelly beans. Smokers actually have a little hypoglycemia, especially after a meal, which sounds strange, postprandial hypoglycemia. So smoking a cigarette raises your blood sugar. We know that. If you can do this, and I've got a citation about this in my list of many citations, you can actually suggest a jelly bean will help. It can't be true, but it is true, and there are good studies to show that. Diversional things like muscle relaxation, even things like reducing but not eliminating your caffeine. We don't want caffeine withdrawals, but we want them to reduce their caffeine intake. Alcohol is a tricky one because you lose your ability to say no, which is a bit tricky, and you know, it does have that impact of reducing your or disinhibiting you. Certainly in my case, not much alcohol to disinhibit me, but it does do that. So perhaps not drinking in these first few weeks. If that's possible, don't drink at all, ideally. There's quit lines and smartphone apps. One of the better smartphone apps, by the way, is the addition of how much money you're saving, because people don't realise how much they're spending on vapes and on cigarettes generally at all. They have no idea. Do you put up things like, you know, my home is a smoke-free home? Certainly make it a smoke-free environment. Avoid the smoke I've mentioned before, reminding yourself, and even what they call temptation therapy, visualize yourself where you are saying no to a smoker. Learning how to behave without a cigarette does take time. And I've got some sort of other things. Do you buddy up with somebody? It's not always a good idea. It can go either way. So there's good evidence to say maybe yes, maybe no. Do you tell everybody you know I'm quitting? Well, again, that goes either way as well. You can go, you know, you can say, look, everybody, don't offer me a cigarette. I'm trying to quit smoking. And they've had terrible results with that when you have had a lapse. So be cautious about always saying it's a great idea to tell everybody. And as I said, fast-acting NRTs are a really good help, a really great help. I've talked a little bit about e-cigarettes. I'm not going to cover it tonight. We will be covering it at another presentation that I am giving shortly, and you'll be notified of that, about what is going to happen with vapes and what we know about them today. So in summary, your roles are substantial in helping manage their smoking. If you address it in a particular way without sort of, as I say, giving them that intimidating line called, you've got to quit, you know, people do need pharmacotherapy. I think it's unconscionable to not offer it. I actually think it's negligent to not offer it. I really think some of our smokers are so dependent and they will have tried. If we assess them and ask them what their experiences have been like, dispel the myths, tell them about what you know, this helps them hugely. They don't know a lot of the things that I've just told you. You know, be well informed. This is not a topic. I'm hoping that tonight I've informed you of some material that you didn't know before that you can impart to them, and be proactive about, say, pharmacotherapies when it's appropriate. I'm just concluding and reminding you that it's a chronic and a relapsing disorder. This is what all addictions are, and nicotine addiction is as well. It's not a one size fits all. Having your mind a medical model, this will help you. You know, consider harm reductions strategies that progress to nicotine abstinence. That's the idea. Nicotine is not benign, and it's not benign in the brain at all. Reminding yourself to give them tips that are based on evidence. Don't just think that I think this is a good idea, but give them things that are a good idea that does have science to support it. And reminding yourselves about the environmental cues and how important they are. And I do apologise to having gone over time. And I think that is my last slide, except to tell you, yes, that we do run a course, and I'm the lecturer. And if you'd like to have a micro-credential in a postgraduate university course on this topic, please have a look at this. We teach it at Avondale now, and it is a micro-credential as an accreditation in smoking cessation and nicotine addiction. Here are all the citations. There's a lot of them, and you're welcome to have a look at all of them. And I will now stop sharing.
I think I'm back on. Hey, thank you so much, Professor Bittoun. Obviously, there's just been like a lot of information.
A lot of material.
And I know that the audience have really got an insight as to, you know, the depth of experience and knowledge that you have in this space. Obviously, we've run out of time for extensive questions. So can I just ask one quick one to you? And that is, the question came up on if, when counselling people using pharmacotherapy for smoking cessation, what would you recommend in terms of the optimal follow-up schedule?
What the schedule should be would be something like you'd be seeing people at least, sorry, I'm just looking at what other people have been asking. Of course, the schedule would be at least 6 to 8 times. You see people 6 to 8 times over a period of 3 months.
Over 3 months?
Yes, over 3 months.
Yeah.
Thank you for that. That's a good question.
All right, well, we are well out of time, but I really want to thank you, Professor Bittoun, for sharing your wisdom and your knowledge. And the good news for everyone who is present, if there are so many slides that were going pretty quick and you're thinking, I missed that, the good news is that this is recorded, and even you'll see at the end there, Renee's actually flashed up the references, so you'll be able to go back to that recording, pause the video and see those as well. And she's also happy to share her a PDF of her PowerPoint slides as well. So yeah, we really thank you for joining us. As Renee has indicated, she is really the expert in my mind in this space. And at Avondale here, we actually offer a micro-credential in nicotine addiction, smoking cessation. So that might be something you'd like to learn more about, and you can look into it. But apart from that, really thank you for joining us tonight. And yeah, you look forward to, you'll be hearing from us soon with the link to the video presentation. But yeah, thank you for joining us, and thank you so much, Professor Bittoun, for sharing as well.
Thank you. Thank you so much, everybody. And good luck with it. Good luck with it.